experience in this field of managing children with neurodevelopmental and behavioral challenges. I'm predominantly from Victorian background. We could sort of divide today's webinar into three aspects. One, looking at the behavior specifically to understand what does the behavior mean. And other aspect is to looking back to see where is this behavior coming from. So we look at the behavior specifically and then try to understand why this behavior is happening. And then we can sort of try to work together on the webinar. We'll see how much we can to see whether we can come up together to have a common management strategies and supporting families with children with challenging behavior. Why do we need to have a understanding on challenging behavior? We know it's very common in our practice. There are data worldwide and everywhere, even in Australia. This data from Victoria showed 1 in 4 children showed evidence of behavioral disorder requiring some degree of intervention or some level of intervention. And almost 50% of these preschool behavioral problem can persist and develop into childhood neurodevelopmental or mental health problems. So they can stick around and continue to cause challenges. If we look from the other end, behavioral problem in youth or young persons, the numbers are anywhere between 1 in 4 and 1 in 5 Australian youth, and they can be sort of grouped into 2 categories: significant externalizing problem like oppositional behavior, hyperactivity, ADHD, aggression, or internalizing difficulties, anxiety, depression, functional somatic challenges. And we do see these presentations commonly both in a primary care setting as well as in emergency department in a secondary hospital-based setting. Because both groups can evolve into significant antisocial behavior, substance use, and suicidal behavior as well. So it's a significant burden on the community and on the healthcare service provision as well. So let's look at ABC of behavior. What's really happening when we see a behavior? Families usually tell us, the behavior comes out of the blue. We can't understand. He was angel, and then suddenly he turns into a monster. May not be in the same wording, but that's usually the description you get from families. But what they find it hard to see is the phase between the calm, happy child who converts into this child who's aggressive or oppositional or doing a tantrum. There is a period in between where child goes through a degree of emotional challenge before the behavior manifests, and the families many times struggle to pick up that phase. So we call that as the amber or the yellow phase, or the active phase. So a green phase is where the child is calm, happy, content, playing, having a good conversation. The red phase is where the actual behavior happens. That's the reactive phase. Whereas the amber phase is probably more useful to understand and maybe even prevent the red phase from happening, is to see the child's emotional challenge, where the child becomes a bit anxious and aroused and agitated and distressed. So that the typical, the ABC of behavior, where the child is stable and there is a trigger, and the trigger leads to the active phase or the amber phase, and then the behavior happens. And then there is a consequence period as well, the blue phase, where the child is calming down. And that phase is also important in terms of how do we support the child during that phase. It becomes part of the management plan. So the theory behind the conversion from the green to the red phase of a behavioral challenge can easily be understood if we go back to embryology. In the brainstem, which is our primitive brain system, is the one that develops first. That's responsible for our sensory motor input and survival. That keeps our heart going, the respiration going, and the vitals of our bodies controlled by the brainstem. Then the midbrain or the limbic brain develops, that controls the emotions and the warmth and the attachment and the hunger and the feeding. That part of the brain develops next. And the third development is the advanced critical thinking part of the brain system, the cortical brain, and that controls our thinking, attention, focus, learning, listening, inhibition, and also our ability to problem solve and negotiate and resolve conflict. So when there is a distress, when the child gets emotional, the midbrain or the limbic brain system gets very active. And it's true for all of us. When the limbic system gets very active, our ability to connect to the cortical brain system becomes impaired. And that the level of impairment varies from child to child, depending upon what other neurodevelopmental challenges they have. But that impairment is there in most of us when we are in a distressed state or situation. So when that happens, the cortical brain goes for a hiding, and then the emotional brain takes control of the console, which drives our behavior. And that's what comes out as a behavior of agitation, kicking, screaming, tantrum. And it gets into that hyperarousal, fight and flight kind of a mechanism. I think that's what sort of shown in this slightly complicated picture. So when we need to feel safe for our thinking and problem solving smart brain to get activated. When stressed, our emotional brain takes over, and that's very impulsive fight and flight mechanism as compared to reasoning and logical problem solving. I'm going to stop there. I don't know that Nazia can hear me. So there is a Q&A.
I can. I will just launch the first poll.
Yeah.
So we can start with the first quiz. Is that okay?
Yeah.
I have launched the first question and we'll wait for everyone to respond. Okay, getting in a couple of answers. And we also have a question from one of our doctors. She is asking, does the percentage of behavior problems differ from ethnic background in Australia?
Yes, is the simple answer. And there is the culture plays a part, and intergenerational trauma plays a part, and especially in the parental upbringing, what strategies they have. So there will be variation with how a particular child's behavior is being managed from one ethnic background to another ethnic background. Yeah.
Thank you, Dr. Sabha. Our answers are almost there. Like we have 42 responses, and I'll end the poll and share the results.
The results are not coming to me.
Are other people able to see it? Are you able to see the poll, Dr. Sabha?
Yeah, I saw I can see the question, but
Okay. So pretty much everyone, all of them, 100% answers state the same answer, understanding the underlying causes and triggers.
and that's what we talking about. Yeah.
Yes.
Right. Okay. So if there are no other questions, we can move on to the meaning of behavior, or where the behavior is coming from.
Dr. Asim Khan may have a question.
Yeah.
He has raised his hand. I'll ask him to unmute.
Yeah.
Hi, Dr. Sabha. My name is Dr. Asim Khan. Just a quick question regarding the prevalence. It seems a bit too high, 1 in 3 for under 3 years of age, and 1 in 5 for under 5 years of age. I'm just wondering whether it's not just like an over estimation of this prevalence, because in this age group it would be a bit difficult to actually identify the actual behavioral problem and discipline problem as you might see in some of the cases. So to me it looks a bit higher, estimating 1 in 3 child to be parents not disciplining the child. Most of the time we see in general practice it appears to be that, and then you don't see much of actual behavioral change. So that's my question. Is that what in your practice, or I'm being bit too thinking too much on these
I think
numbers?
that's a very good question, because from a study perspective, they have a standard protocol, what they considered as a behavior reaching a disorder level, and the data they've taken for that particular study is more into a child needing some degree of intervention, that not necessarily seeing a general practitioner or being referred to a pediatrician, that may be involving maternal child health nurse, and going through some health information, or seeking integrated family support, or going through some degree of parental training, circle of security, so that level. So from that perspective, the number does seem high, but we will talk a bit more about in the next section as well. The behavior comes from the perception of challenging behavior comes from mismatch. Say, for example, say in a clinic, a child in a clinic, 6-year-old autistic child with very minimal verbal input, who has minimal regard to other people, who he's in a mainstream school, and he goes to school. He doesn't follow the rules of have to sit in the in his chair and listen to the teacher. He goes and he interacts with the environment in a different way. He likes to smell things, like to taste things. So from his perspective, he's just learning and dealing with the world, and mom can manage this behavior at home. So for the family, it's not a challenging behavior, but the school, finding it hard to cope with his behavior. So, it's not the right thing, but, they they've reduced the number of hours he can spend in the school, and they can't manage with even with the extra support person. So the capacity to support a child who is presenting with challenging behavior changes from a person to person, situation to situation. So it's hard to describe a cutoff point of a challenging behavior from a child's perspective. We always have to take the family or the team's capability into the equation as well. So we will succeed in supporting the child if the capacity is very close to or slightly above the child's ability, and the expectation stays at the same level. If the expectation is artificially high, then the child's behavior is going to be challenging. I hope that makes sense. But
thank you very much.
We'll go through the next section and we'll try our best to get that in place.
We also have another question, Dr. Sabha, and I apologize if it's in the middle, so please let me know. Yeah.
No.
Okay.
We will stop and start. That's the best way to deal with it. Yeah.
Sure. So one of the doctors are asking, does trauma bring antepartum or postpartum period take part in behavior development? Does trauma during antepartum or postpartum period, take part in behavioral development?
Absolutely, yes, because it's still a developing brain system, and that brain needs secure attachment. I'm presuming they're talking about developmental trauma, not physical trauma, but physical trauma absolutely, yes, can cause problem to the brain system. Developmental trauma, the child needs safe, secure, and comfort attachment, and when the family is going through those challenges and there is deficiency in providing that secure attachment to the child, and that child gets into the chemical change and hyperarousal state, and that more often pushes the child into the challenging behavior category.
And there's one other question. So one of the doctors are asking, what exactly is challenging behavior? Like, what would you define challenging behavior as?
Yeah, well, I think we might have 1 or 2 slides to cover that. Yeah,
absolutely. Sorry.
That's okay. Yeah, right here. So we'll move on. So to understand challenging behavior, I've grouped them into 3 different categories. Things that we need to understand is, first, the challenging behavior is, we need to decode the distress. The child is in a distress. The child, the behavior is a part of communication. The child is crying out for help, and he can't bring, or he can't request that help in a proper manner, and that's where the behavior is coming from. The child gets upset, thinking brain shuts down. The child could have good verbal communication ability, but when they get distressed, that part of the brain gets shuts down, and they go back to the previous level of brain development, which is to cry or agitate and get into that fight and flight mode. So the behavior is a mode of communication, and that message needs to be given in a clear and supportive manner to the family. And the behavior is a mode of communication, and as we discussed, the distress switches off the rational brain, and it's a mad animal type of a brain function. It will distract anything that's come in front of it. The second way to look at it is, with challenging behavior, there is a degree of incentive imbalance, and that's where we talk about negative punishments and stuff. But generally speaking, when a challenging behavior or a behavior happens for the child to get something, and most often than not, as a carer or a parent, we give in inappropriately, and the child gets a reward that the child should not get in a normal situation for that behavior. And then the next time when the child is tired, needs that, the iPad or the phone or, the child or the TV, the child goes back into that behavior mode because it has worked before. And then few times the family given, then it becomes a habit. Anytime that child needs something, the behavior comes out. And also, again, a common challenge is to see the good behavior the child is doing, and actually communication of the child in an appropriate way, it gets missed and doesn't get rewarded. And a child asking politely for a phone, or after doing a job, that needs to be acknowledged, and or using words to describe things needs to be acknowledged and appropriately encouraged. So that, again, many times what we see with families, about what they think is challenging behavior, is they overdo with accidental rewards and underdo in appreciating the good positive aspect of the behavior. But the most important aspect of challenging behavior is coming from mismatch between the child's ability and the family's expectation. And this is what we were talking about earlier. The child's ability, can be assessed from few different angles. From a cognitive perspective, the child have problem with their cognitive development, and so they cannot express their thoughts clearly and quickly. So when that happens, there is a temporary arrest, so they go to an angry or a meltdown behavior. And the child may have problem with focus, concentration, attention problems, so they can get easily distracted. The child can have problem in retention or remembering details, so they try to make things, and that will be interpreted as the child who is lying deliberately. And a child may have problem when have challenges in problem solving, and that will be interpreted as a child does not have any resilience, and doesn't want to do things and stuff. So the cognitive ability of the child varies from one child to another child. The cognitive level, not everybody at the same level. There's a wide variation of normal cognitive ability, and that understanding of where this particular child's ability need to be sought, rather than assigning that behavior as a challenging behavior. This is more from a family perspective. Now, the mismatch may come from the emotional development. Some children find it hard to have self-emotional awareness. They don't notice that they are getting irritated. So they get into the angry meltdown behavior very easily. And they also have, they may also have difficulty in seeing others and reading others' emotion, and so they might come across as being disrespectful, and they can get overwhelmed, and that can come across as lying and cheating, that kind of external manifestation of a behavior. So there is mismatch because of the emotional development of the child, and there may be mismatch because of social impairment. A child's not aware of others' needs, nor not aware of others' space, and can't relate to others in a positive way. And these all can present as annoying and refusing to follow instruction, and then it generally gets into a conflict, and then they resort to aggression as a final way of getting out of that situation.
Dr. Sabha, there's a question. Sorry for interruption. How much of this behavior relates to parents' behavior? So parents are more of the issue in the current scenario. So it's like a reflection of their own issues.
So it's not, suppose it's, it's not a straight one way, how much is related to parent, and everything plays a part. I do have a slide a little bit later on, which kind of gives us a picture of how much the nature contributes and how much the nurturing contributes to the challenging behavior. So maybe we can talk about it there. Yeah.
Absolutely. Thank you.
And there are some children who have physical problem, physical problem, not necessarily like something major like cerebral palsy. They can have problem with sensory processing. They can have problem with some degree of visual impairment and balance, coordination. Again, so they will refuse to do, and that again leads them to behavior that may be interpreted as challenging behavior. So I'm wondering, is it time for us to do the next question poll, or?
Sure. Why not? And I have launched the second poll. We'll wait for everyone to reply. So what does a problem-focused consultation and support involve when addressing challenging behavior in children? So we have about 10% responses. A few more seconds. All right. Almost 70% have responded. A couple of more seconds. Are you able to see the responses or the answers, Dr. Sabha, yet?
No, but that's, yeah, you can tell me, that's fine. Yeah.
Sure. So I think everyone's inclined towards identifying specific issues and developing targeted strategies. So I'll share results now.
Yeah. Yeah. Okay. Sure. Yeah.
Thank you.
And that's hopefully that's what we will take out of this session. So talking about challenging behavior, what families see or what they tell us when they come to consultation, that this child is acting out and is always attention seeking, manipulative, is defiant and aggressive. But it has internal meaning is different. A child who's avoiding, withdrawing, it's more a flight response to take them away from that situation as a self protective mechanism. A child who's defiant, fighting, is trying to put his point across on a perceived or a misperceived threat. Acting out is just emotionally dysregulated child, and manipulative is he's just seeking what he thinks is the right thing to meet unmet needs, people not acknowledging and giving him a choice, or giving the child a choice. So what we see or what the family see has the inner meaning, and that's what we need to find out. So as I mentioned, it's slightly busy slide. What does a challenging behavior, where does it come from? How much parenting plays a part. It does definitely have a role, the parenting. So on the left side of the slide is the nature, where genetics, we know some neurodevelopmental conditions like ADHD and autism have a very strong genetic connection. There are other conditions. There's a lot of development, a lot of advances in genetic medicine, and to identify certain gene changes associated with certain type of behavioral challenges. Fetal toxin exposure, fetal alcohol spectrum disorder, and child with different temperament can present with challenging behavior, and intergenerational trauma, socioeconomic disadvantage, ethnic differences, parenting, and parental behavior and peer behavior in front of the child also influences the challenging behavior. So and they're not just directly causing challenging behavior, and they some of them can influence other aspects of development, and they all lead to challenging behavior.
There was a question, Dr. Sabha. It was actually more of a request. Can we please have some case studies? Probably I'm assuming they need more examples, live examples. And there's one more question. How much medical investigations regarding blood tests and brain scans need to be done?
We'll talk about management. We'll come to management. We'll leave the management question later on.
Thank you.
Case studies. I'm happy to give case studies, but it'll be more useful if any one of you want to share cases that you're dealing with, you're helping with, then we can try to problem solve as a group.
So any GP, any doctor who may have recently encountered, or could be a practice nurse who have recently encountered something, please feel free to raise your hand and we can have a direct discussion. Thank you.
Move on.
Yes, please, Dr. Sabha. Thank you.
So now, can we put challenging behavior into a category? We know, oppositional defiant disorder is probably used often as a diagnosis, sometimes with ADHD, sometimes without ADHD, but it's probably the most commonly used diagnosis when we faced with a child with a challenging behavior. Typically, a child with oppositional defiant disorder has a sort of baseline change in their mood. They can be stable, but they can lose their temper easily. They're very touchy, easily annoyed, and they easily can get angry, and also their behavior towards the third person or second person, they're always arguing, actively defying the rules of the home, school, and deliberately annoying others and blaming others for the fault, and sometimes they can be vindictive and spiteful towards other people and animals and stuff. So it's a commonly used diagnosis, oppositional defiant disorder, and that's many children referred to challenging behavior will probably sit under this category. It's still not clear in terms of whether oppositional defiant disorder or ODD, as we all write in our letters, whether it's a disorder on its own, or is it just a manifestation of something else that's underlying. There's a good argument, and then with a lot of studies done in US as well, where they see ODD as a subtype of ADHD brain system, rather than just giving it as a separate diagnosis. So management strategy. So this is where do we need to do tests, and do we need to do blood tests and neuroimaging, and what do we do? So I'm going to. So we'll probably have a chat next. We still got a bit of time. I've got a bit more slides to go through, but not a lot. So what do you guys want to shout out, or in the chat, or what should we do when we face with children with challenging behavior? We can try to group them, have our answers. You can come off the screen, or shout or type.
This is a very interactive way. So if you have any comments or anything, Dr. Sabha will combine them and I think color code them separately. Everyone, please just pop in your answers. We'll be happy to just categorize them, I'm guessing. This is new. This is the first time we're doing this. Very interesting. Meanwhile, there was a question again. What's the point of making an excuse for diagnosing opposition-defined disorder for a child's behavior?
That's one way. I'm sure when you make a referral or when we see the child, that's not the purpose to make a diagnosis of the child. And again, I always tell the family, the focus is not on the child. The focus is on the environment. How we can make things easy for the child. How do we help you to provide that tools and strategies that bring you up to the level to manage the child. Sometimes I call that the normal parenting won't do. You need to be a super parent. You need to have near normal strength. Your friend might get away by having a 70% battery in the system. They might, the friend might go for a drink on a Sunday evening with that 70% battery, might able to function very well on Monday morning, but for you need 100%. So how do we make sure we give you the tools and strategies? And with that ODD diagnosis, the diagnosis doesn't give anything to the child from a disability support or a carer payment. It at least gives a platform to explain to the family to manage ODD, you need to learn positive parenting. And that is not teaching you how to do parenting. That is teaching you what strategies you can have to manage the tricky child. So that's different. At least that gives us a platform helping the family. Yes, we acknowledge there's an issue. It's challenging, tricky behavior, but we're not talking about fixing the child. We're talking about giving you the tools and strategies to manage the behavior. I hope that answers your question.
Thank you for that, Dr. Sabha. We do have 3 responses. One is weight and height.
Okay.
Another one is observe the child in the family setting.
Okay.
And there is the third one is deformity.
Okay.
And is the child behavior in a school setting or teacher's observation, does that also count?
Yeah.
That's my response.
The deformity is
yes. All right, we only have 3 to 4 answers. Is there anyone else who want to just pop in their answers so we can categorize them? Dr. Sharif has raised a hand. All right. Okay. I'm guessing that was by mistake.
So, whatever strategies we think have a role, and that's why I put the slide in there. Yes, we need to look at the child's nutrition, we need to look at the environment and what modification we can give to the environment, and we can look at, is the problem at home or home kinder or home school. For us to diagnose a disorder, generally most of the mental health conditions like ADHD, autism, and the challenge needs to be in multiple setting. That's why commonly we screen for ADHD from home, from teachers, school, and see how long it's been persistent. And they need to be there for a, mostly DSM criteria. It will be more than 6 months and more than one setting. So yes, for a disorder. But we also know children with mild oppositional defined disorder who meets the criteria can initially be at one setting before it gets into the other setting as well. So for managing, we know even if we talk about blood tests, yes, some children with iron deficiency can have an increased tantrum as compared to children without iron deficiency. The data is not very strong, but it's iron deficiency is a treatable condition. So if the nutrition history suggestive of inadequate iron intake, because many children with challenging behavior are fussy, with what they eat and how they eat, and so it highly likely they have some degree of iron depletion that may lead to anemia or not, but they have degree of iron deficiency. And you also don't want to miss the organic things like celiac that can present with the degree of irritability and things, simple things like thyroid problem. And have I seen a child with thyroid problem presenting with challenging behavior probably not, but it's one of those things that where people check because it needs to be treated differently. Have I seen celiac screen presenting with irritability? Yes, quite a few times. Do I see children with iron deficiency, whether it's a coexisting problem or rather than a cause and effect problem? There's a lot of children with challenging behavior will have iron deficiency. Sorry, did you have a question?
Yes, thank you so much, Dr. Sabha. So there's a doctor mentioning that they find with teachers in WA, if a child doesn't fit into the box, they are sent for either ADHD or autism assessments.
Yeah, and suppose don't mind ADHD, it's relatively common, 1 in 15, 1 in 20. Autism is really challenging, and I don't have an answer for autism because, and you probably all seen the headlines in the recent weeks with the significant spike in the level 2 of autism diagnosis and how it's sort of eroding or rotting is the word I think they used, the NDA system, and even Autism CRC executive, Autism Victoria executive, they voiced their concern as well. And there's two ways to take it. Yes, we are diagnosing more and more children who might have a soft impairment with the strong high level of autism, and that's, I think it's a evolution because of the need, a child sitting in not in any setting without a support, and that progresses over a period of time is more challenging. So people, I think because of the way the NDA system is designed, and they know if you assign a level 2 diagnosis, you get NDA support. So there's a lot of push and drive, and suppose there's getting an autism diagnosis, which is unfortunate, but there's no easy way around it. The one way I excuse myself is at least we are getting an standardized evidence-based therapy support using trained professionals from speech and OT and psychologists. You just need to trust them. The therapy they are providing will help this child now, and if we help this child now, then at least the long-term damage and the spillover effect of the healthcare system of an undiagnosed, untreated autistic spectrum, would be limited. So that's one way of looking at it. So there's the educational system wants ADHD or autism. Again, it might vary from one place to another, how the Department of Education functions in different state level. Children with autism, depending upon their language ability, will attract some degree of funding, additional aid support. In Victoria, it's clear they have to have severe language deficiency. That's not the case in Queensland and New South Wales. They just have to show the adoptive day-to-day behavioral challenges. So that people want that diagnosis. With ADHD, again, unfortunately, we end up where most of the children end up being on medication. That does help. So it helps the environment in the educational system. So they want it to be sorted out and looked at. So that may be the reason why they are keen for a diagnosis of autism of ADHD. So in the immediate management of behavior, is to get the family to understand they need to do something to calm the survival brain, and they need to connect to the emotional brain. They need to help the child to use the thinking brain. It's easy said than done. We call this zone of regulation or window of tolerance, and the aim is to bring the child into that state of calm, alert, and relaxed. And it requires time and education for the family, for the child, and for them to be aware of their emotions, and then identify emotions, and then use a strategy that may be, doing deep 5-finger breathing or box breathing, or having a sip of water, or listening to music, and finding out what works for a particular child depending upon their age level. Is the idea is to bring them from that hyperarousal zone back to the optimal functioning zone. And sometimes it may be simple. The family may be able to identify what works for them, and sometimes they need professional help, occupational therapist or a psychologist. So generally, the window of tolerance in an otherwise normally developing child without any other developmental concerns or any other neurodevelopmental diagnosis or without trauma, that window of tolerance is wider. They function, they perform in that level most of the time. Whereas the child with the neurodevelopmental problem or trauma and other issues, that window of tolerance is quite small. So they easily get into that either hyper-aroused state where they get into that fight-flight response, or they go down into that hyper-aroused shutdown, flat emotions, and lethargic kind of behavior.
Dr. Sabha, there's a question, and I think a lot of GPs and a lot of even parents have the same complaint or question. Don't you think that we are finding more excuses and they are more frequently diagnosed children's behavior? Why this now and not years ago? Like, why have this suddenly increased? And I think it's a very common question.
Yeah, I think, the focus needs to be on the early intervention, and the NDA system did get it right from that perspective of not seeking a diagnosis for children below 7 years of age, and the early childhood early intervention support is all about seeing the challenges and supporting the challenges. I suspect the families are all, they get into into a shell and independence of their own, and they compare themselves, and there's a lot of social pressure and peer pressure, and they want a child who performs in that ideal line without any degree of variation. And then that gets into, and then they come to seek help from you, and then they come to pediatricians. And I think it's a bit naughty on the medical system as well, is when somebody is seeking something, we all are obliged to give something in terms of giving a diagnosis. I think they've gone on the days of, this is normal, don't worry. The family don't stop. They seek, if you give that answer, they go to the next medical clinic until they find someone who can say as to what they feel and then get referred to a pediatrician. Again, if one pediatrician says no, they take next person. So it's a
Right.
tricky area, but
Yeah.
certainly there's more diagnosis happening, and there's no doubt about it. Yeah.
So for a GP who is very seasoned and experienced, and they've seen all, I don't know, generations, as I would say, they find this a very difficult topic, and something which they find it very difficult to digest as well.
Yeah.
So,
Absolutely. That's the system doesn't acknowledge the importance of the primary care physician, the general practitioner, who has the best 360 view of what's happening in the family, and the system doesn't support them with time and the way they, the clinic timing, and or how they, I suppose the financial incentive in terms of managing these children from their perspective. I don't know how they can do it in 15 minutes, but they know what's wrong, what are the challenges for the mom, what are the challenges, if the family, if it is a town, it's only
right.
if the family seeing the GP for an anxiety and depression, and dad as a substance use problem, the GP would know where exactly the challenges are. The mom does not have the right mood and emotions to challenge, the dad does not have the right impulse control to challenge the behavior, and so a small behavior becomes, the family starting to see with the microscope to see, blow things out a bit more, where a GP who knows the family very well can say, maybe we need to see what we can do for your well-being, or maybe, you need to go through this AOD program, which we are missing. And that's not a complaint towards the
So I
group.
think for like primary doctors, I think they would be like connecting the dots more frequently and better.
Absolutely.
Is that okay?
And like,
Yeah.
so again, when families, yes, we come to the pediatrician, we're supposed to have a good biopsychosocial perspective of what's happening around the family. Many families, they don't share that information adequately. Even if they share, it's just a note rather than the GP who knows it like a video or a period of time, what that particular family is gone through or going through. So they are in a better position. And again,
Right.
there is a lot of push for pediatric service delivery to be delivered at the primary care level in combination with the general practitioner. I think the UK is moving into that model as well, where the pediatrician should be present with the GP running the clinic to see the kids, so that everything gets shared without
Right.
any barrier of information.
We have a couple of GPs actually raising a lot of statements, and is it, am I allowed to probably unmute them if they'd like to have probably a discussion? Is that okay?
Yeah, absolutely.
Yeah, Dr. Prakash and Dr. Prakash, would you like to probably unmute yourself? Is that okay? I'll just let them go ahead. A few people actually saying school teachers are diagnosing ADHD. Yes, please go ahead.
Yeah. Hello, I'm Anuradha Prakash. I'm just saying, as I said, that I've seen the child even from when they've been from age 1, and when they started going to school, the school teachers are, as soon as in the first term, and the kids have some sort of behavior, they just labeling them that they got ADHD, just go to the GP, get a referral, go to the pediatrician, and they were trying to pressurize the parents to get a referral from us. And whatever I'm trying to tell them, this is all, look, probably the first term he's getting used to the thing, the parents are compelled by the teachers to get a referral to see a pediatrician. Is that thing happening to other people's here? That's what I wanted to ask.
It's probably happening, Radha. And thanks for raising it. And it's again, it's not I think there's no one dimension to that issue. We know the typical ADHD can be diagnosed in the preschool category. That child will be significantly hyperactive, impulsive, and it'll be very visible. So that's only small group of children that we diagnose with ADHD. So I'm not supporting every child to be to be sent to to you and then to us. I'm not supporting that statement, but the education in early child education care and providers, school teachers, they all been given information and taught on ADHD screening and what to look for. So many times they acknowledge or they see the challenges, but depending upon their experience, some of them might rock the boat early on. Some of them does not have that. Let's support scaffold for a term and then review how things are, and so they don't have that capacity to work with the family. So invariably, the words get mentioned, and then parents Google or friend, and then they say, oh, or get it checked, and then they come for referral. But I do see that pattern of school is worried and coming to you and coming to us. That's happening. So I don't know about the experience among the group, but certainly I see that pattern as well.
Thank you.
Can I just pop in and add a comment? This is Usha.
Absolutely, Usha. Yeah.
I agree. I think I get most of the children, ADHD may not come, but it is autism and autism associated spectrum disorders. And most of the parents, I think in Canberra, they know what they are talking. I think they will Google it. I don't know. And they get with school assessment report. And their expectation is just referral and getting the diagnosis. And I usually don't argue with them. I just put a referral straight away because that reduces the stress to the family and even to me. And ADHD is not so common. I've come across in teenagers and bit more than 10 years old. That's what they ask for that. But usually I come across in Canberra more autism.
And again, it's a really tricky subject with autism diagnosis. We diagnose the typical autism, but many times there's a lot of children come to us already having gone through, the proper autism assessment, where there's significant amount of pressure on the families to have a diagnosis, on the doctors to give a diagnosis, where they might meet the criteria, but their functional impairment is not anywhere near that level 2 autism that gets direct entry into the NDA system. But that's really, I don't think anyone has an answer for it yet. Otherwise, they would have cracked it. But there's a lot of push and a lot of false elevation of autism diagnosis in the recent years. Absolutely, there's no doubt about it.
Thank you.
Just one last question before we can let you continue. I'm sorry. So new GPs are not always as a regular practitioner in large practices. So how are they able to probably send a referral, or how they're able to diagnose better? What should their approach be? A little question on those lines.
And again, it's time constraint is a big challenge, and if they are new and if you have a locum GP, it becomes very challenging. The easier option is to make a referral. It's almost like us getting into that hyperarousal state and then just going on the back road. Let's just put in a referral and get done with it. Challenging behavior is to sit down with the family to say, okay, yes, the child will go through a diagnosis process. That's not the question, but what are your challenges? What are you struggling to meet? Is it lack of information about sleep hygiene? Is it lack of information about gadget use? Is it lack of information around diet? Is it lack of information around sleep hygiene and stuff? And giving that information, and or what support you're lacking. Do you feel with the child with significant fussiness and sensory issues? Do you need a chronic disease management plan to see a occupational therapist? And is the child's communication is challenging? Is the child understand what you're saying? Is the child able to communicate back? Do you need to see a speech pathologist? So seeing, rather than getting into a diagnostics category, trying our best to see where the impairment is. Is the impairment in speech and language development? Is the impairment in impulse control or sensory regulation? Is the impairment, the trauma, emotional? And then trying to at least provide that immediate and local support as much as you can, while referring a patient to pediatrician required. And I do get a lot of children with the challenging behavior because they have language impairment. They can't understand and they can't communicate back, and they resort to tantrums and aggression. And many times they just need help from a speech pathologist to help to understand and communicate to the child in an effective and a meaningful way. And they don't really need to come and see a pediatrician, but what happens.
Thank you.
So
I'll let you continue.
Yeah, no, I think we'll be nearly there. So again, we talked about the ABC, which is the antecedent and the behavior and the consequence. Once the behavior happens, we can only focus on how do we deal with the aftermath, which is the consequence. But the antecedent is important. The things that we don't need to do is on the top left. We know the child is challenging, but we make it even more harder by not giving adequate time for the child to transit from one activity to another activity, or calling out without getting the child's focus and giving instructions, or talking to the child across the room, or many times treating the child as a grown-up adult with their communication, and that those things leads to behavioral problem. But they should rather do what's on the bottom left, is to adjust to the child's level, making clear expectations and using sort of visual prompts and visual guide as much as possible, and giving visual countdown for transition. Your timings finishing. You got 30 minutes on the computer doesn't mean anything for a 4-year-old or 5-year-old or a 6-year-old with ADHD. They don't have any time concept. You need to have a clock that goes off, or a half-hour clock and something, those kind of things. And also help provide the child with the choice of what they need to do, rather than sort of pushing our choices into the child. So if we get the triggers right, then the behavior will not happen. And then giving that information to the family is acknowledging, yes, it will look as if the behavior is coming without a trigger, but if you go back and look at it, you will find what's leading to this behavior, and then work on what you can change in the trigger that will avoid the behavior from happening. And with the consequence, again, the focus should be on what on the bottom right is about giving positive reinforcement and giving reward for good behavior, rather than a child crying for something or throwing a big tantrum, and then we're giving it because that stops the tantrum. That's kind of positive consequence to what the child is having. So we should avoid those kind of behavior, or help the family to avoid those kind of behavior, and also delayed consequence and then disproportionate consequences. These children do not have capacity to carry those behavior for a longer period of time. They've done with the behavior, they move on. And so it has to be there and then itself be very clear with how we react to those situations.
Talking a little bit about the consequences, we do have another question. Dr. Ramakrishna asks, what's the prognosis, long-term prognosis for these children, as in 1 to 5 in a large proportion? Would some of them normalize in time?
It's children with challenging behavior without any neurodevelopmental diagnosis, who has reasonable cognitive and communication ability, that behavior will settle down. Because if we look at from look at the cognitive theories of how the mind develops, once they reach 5-6 years of age, the higher the reasoning centers really kicks in, that creates the how, why kind of curiosity in our brain system, and they communicate better and they understand better. If a child has ADHD, typical ADHD, that is leading to that preschool problem behavior, and that the hyperactivity might settle down, but they will continue to have problem with focus and concentration in the later years, and that will invariably lead to a lot of internalizing issues with anxiety and somatic and functional issues. So that's the reason I'm not against a preschool teacher, asking the family to go and get assessed. So we don't want to miss that typical ADHD that is presenting in the preschool age group. We may not medicate them, but at least it's getting that family to understand, your child can't focus for more than 2 minutes. You can't make the child to focus for more than 2 minutes. You need to adjust your expectation accordingly and have that support around the child. So yes, if they don't have a neurodevelopmental problem, the challenging behavior will get worse unless they are supported. But generally speaking, otherwise, a normally developing child with normal cognitive ability, the oppositional defined disorder settles down.
So there's also another question statement. So there should be mandatory parenting courses. I'm just assuming that's more of a suggestion and question at the same time.
Yeah,
Yes.
Again, any child that I make a diagnosis of ODD, I tell the family that this is the first step for you. You need to do these courses, and again, depending upon the state and where and what's available, but there is triple P positive parenting online that's available Australia wide now. It's free. I think they run 6 sessions. It's on positive parenting, and some places they, especially New South Wales, they run a lot of circle of security for early years parents, and they do provide that locally within their community. So parenting any child with challenging behavior, that preschool child that comes to your clinic with challenging behavior, positive parenting will definitely help. And it's about how we sell it to the family, in terms of, this is not to teach them parenting, this is to give them that extra tools to manage that tricky child.
All right. Thank you, Dr. Sabha. There's one more request. Could you please repeat what you said about the problem with positive consequences? Thank you.
What do I mean by that is, if a child is doing a behavior to seek something, and we give in, or the family is given most often, because that stops the behavior. But that becomes a habit. It's like a child crying for phone while eating, and we give in because we feel eating is important, and then that becomes to be, every time when the child sits in front of the meal, the brain automatically goes, I need that phone, and then until the phone is there. So that's what I meant. We need, the family needs to work out, have a clear plan of when the child gets the phone, and then be consistent with it. One person doing differently, one person acting on a different emotional state sort of confuses the child and makes the child to act even more out than understand how the system works.
Thank you, Dr. Sabha.
So again, it may be just sort of a slide. I'm just mindful of the time. How do we provide, what happens with the antecedent behavior and consequence. So a child sees chocolate itself and starts yelling and kicking in a shopping or Woolies or Coles, and mother buys the chocolate for the child. The next time the child is more likely to yell and kick and get a chocolate. And so that's what I meant with the consequence and stuff. So that has to be, correct. So if you look at management strategies, that's what I meant, the parenting resource, that's 100%. All the families will need, ADHD, autism, positive reinforcement, positive parenting is very important. And getting the basics right, how healthy is a child sleeping, snoring and other ENT issues, diet, iron levels. Does the child have a good healthy habit of how to use the gadget, how much gadget is allowed, and also the getting in integrated family team support, uniting and other teams. They're very good in supporting and meeting the family's needs in other areas around the child, which will improve the family's time and effort in supporting the challenging behavior. At a professional level, yes, we need to find where the deformity is, not the physical deformity we're talking about language deformity or cognitive deformity, attention focus deformity, as like an ADHD, or it's a social deformity, social behavior deformity like autism. And so we need to identify and support using targeted allied health team and care coordination and being part of the child's management. I think a pediatrician sitting at a level and doing a letter, and a speech therapist sitting at a different level and doing some therapy without a lot of interaction is not ideal. It's suboptimal. I think everybody, primary care clinician, pediatrician, and the allied health team, they all need to be on the same page to focus on what is it making it hard for this family. And also the other question is, what are the good things here, the protective factors in the biopsychosocial formulation? What are the good things that's actually brought this child to our clinic? What are the good things that's making this family to seek help? What are the good things that making this family to bring the child to speech therapy? How do we build on the good things, and how do we bridge the gap with regard to their financial ability and social support and respite and those kind of things? So the care coordination is very important. So I think in summary, the family is the best support system for therapy. And if the family is expecting the GP or the therapist or the pediatrician to fix the problem, I think we just have to try our best to get them out on the front, saying, no, this is, you are the one who are best placed. How will we support you to help your child? And getting that expectation right to capacity, and finding that window of tolerance or window of regulation, and making sure they allow the child to perform in that regulation more often than not. And obviously community support, that's parenting, maternal child health nurse, and integrated family support, and healthcare plan with allied health therapists. They all will help.
Dr. Sabha, there's one question. Apart from PPC, are there any other web info or services in a community to direct parents for the support?
There's a program called Circle of Security. It's designed more for families with younger children. Again, Circle of Security works under the principle of behavior is communication. When the child is crying, he's trying to communicate something to you. Let's not see the behavior as a challenge. Let's see the behavior as communication and try to interpret what's happening. So circle of security and positive parenting, and depending upon different agencies like Uniting in Victoria and Tasmania, they do run sort of emotionally tuned parenting courses, and some services will also do trauma informed parenting as well. So yeah.
All right. I think there's one more question. Are there any online help resources for challenging behaviors? Also, if you have any links, Dr. Sabha, sorry, I'm interrupting. If you have any links that you'd like to share with the GPs, I can actually forward them along with the evaluation as well. Please.
And I don't know, forgot about polls. I don't know how many questions we had, but we can.
That's okay. Yeah.
So in terms of online resources, the resources I generally use for children is the Rising Children Network, which is, I still feel it's underused. Families go everywhere else, Google, but they don't go to the one parenting website that's evidence-based and researched and updated on a regular basis. And they have plenty of information. The other place I do use is Kids Health Info from the Royal Children's Hospital. They do have a fair bit of information. I'm more than happy to send those links to you guys. Yeah.
Thank you so much, Dr. Sabha. Now, if anyone has any more questions, please feel free to raise those, and then we'll proceed for the reviewing performance QR code and a quick 10-minute break, and then we'll continue with Dr. Lalita's session for Eczema and Allergy March. All right, I don't see any active questions, but if we have any, we will definitely share it with you and hope for an answer very soon. Thank you so much, Dr. Sabha. I will be sharing my screen with your permission, and I'll share a link which you can actually access from your desktop, so you can have a reviewing performance. Everyone, is this visible? The QR code? All right. So 10 minutes from now, we will be joined by Dr. Lalita for the next session. Thank you, Dr. Sabha. It was a really interactive, one of the best interactive sessions that we've had so far. Thank you. And if there are any further questions, we will definitely let you know.
Thank you. Thank you, everyone. Have a lovely evening. Bye.
Thank you, Dr. Sabha. For everyone who's online, the QR code is up, and we will be back in another 10 minutes. Thank you. Thank you, everyone. We've received a lot of responses. We'll be starting in another 2 minutes. Thank you so much for your patience. Yes, Dr. Prakash, we will be sending in a couple of links along with your certificates and along with other details also, just after the session, and maximum by tomorrow afternoon. So you should be receiving a few links and services which will be available for the patients. Thank you so much. Hi, Dr. Lalita. We want to welcome you. All right. It's a pretty heavy evening. I hope all of you are not sleepy yet. Just a couple of probably 1 hour, 1.5 hours to go maximum, and we should be good. All right. If you have any questions throughout the session, feel free to just pop in the question in the Q&A. You can also post in as an anonymous question. So don't worry if you have any questions that you don't want to be seen for or maybe highlighted for. So just feel free to put it as anonymous and we are happy to answer those questions. All right. We would like to welcome Dr. Lalita Jindal, who's our pediatric allergist, who will be providing valuable insights into the diagnosis and management of eczema and allergic march. She has an expertise in this field and offer us with a comprehensive understanding of eczema and also allergies. Thank you so much, Dr. Lalita. Welcome. And the screen is yours. Thank you so much.
Thank you, Nazia, and thank you everyone for staying in or joining in. I really appreciate sharing your family time with me tonight, and I promise I won't be very long. I hope I can make this time work for you. So, talking about eczema and allergic march today, I'll start with the aims of my presentation today. I'm going to review pathophysiology of eczema with you all today. Then I'll review role of eczema in progression of atopic march, and then relate that eczema treatment options to the pathophysiology we're going to discuss today. I thought I'll start with the natural history of atopy, which we call allergic march. Although it's not hard and fast rule for every patient who comes with allergies, but quite often we see that if you start with quite severe eczema in early childhood, you end up having either food allergies with or without allergic rhinitis and asthma by the time you are a teenager. And we're going to look into how does that happen, and if there's anything we clinicians can do to interrupt this atopic march. Most people in the group will be familiar with what eczema is. It's just a formal definition from SKA website. Eczema is a chronic health condition that affects the skin, causing redness, dryness, itching, and sometimes infections. So I'll start with molecular model of skin as a physical and immune barrier. So we know the epidermis, top layers, are pretty avascular or dead, but they have this important function in integrity of skin barrier that all environmental interactions are kept outside, not inside the skin, whether it's the change in temperature, change in humidity, irritants, allergens, or pathogens in the environment. If we have a healthy skin barrier, we tend to cope a lot better with these things. In addition to a healthy physical barrier, we are aware of a very active immune system in the skin as well, which also needs to have healthy immune responses to maintain that integrity of skin function. When there is a skin barrier abnormality, it could be because of one of the structural genes or enzymes dysfunction. A lot of times it's genetic, but it can be acquired with age as well. Physical barrier disruption is not enough to cause eczema. So very often we see immune dysfunction, which adds into the physical barrier disruption, which causes changes in skin, which lead on to increased antibody levels, IgE antibody levels, sensitization to allergens. Th2 is a type of allergic T lymphocyte. So they make a lot of cytokines, the chemicals which trigger inflammation, along with chemicals which are released by other immune cells like mast cells. So how it works is anything coming through the skin barrier defect interacts with the antigen presenting cells in the immune system. And these antigen presenting cells, they interact with different types of immune cells to make either specific antibodies or non-specific allergic inflammation. So here we got a normal looking physical and immune barrier. And here is how a disrupted physical and immune barrier would look like, which will allow all the allergens and irritants to get into the skin and interact with the immune system, which is dysfunctioning. As a result, we have the irritants in, the moisture out. And that's what we see in our patients. So we see this dryness because they're constantly losing moisture. And we see all this inflammation because of overactive immune system under the skin, which is interacting with all irritants coming through their physical disruption in the skin. Now, before I go further, I would like to ask if there are any questions on this. I see there's some comments in the chat. Just quickly chat if I have a question on this.
We do have a couple of general questions and people asking next education and about visibility and directions, but no questions yet. I'm just hoping, I think a couple of questions will be raised in the question and answer section very soon.
Yeah,
Thank you,
sure.
Dr. Lalita.
I won't take very long talking about this, and we'll be very happy to take your question. So a lot of teenager patients often ask in the clinic, why do I have it? A lot of times their friends, they would know friends or family members who don't have it because there is a general perception in the community that eczema is hereditary, but very frequently we see that not all the members of the family get affected by eczema in a similar way. And there is this one individual who suffers too much, and then there are others who don't have any eczema at all. And then there are others in between the two extremes. So why do they have eczema? So here's this theory that the outcome, which comes from interplay of multiple factors, causes eczema. So that outcome causes the physical and immune dysfunction at the same time. And when there is both physical barrier disruption as well as immune dysfunction, that's when they have eczema. And this balance can be different for different people living in same country or living in same family because of the genetic variation and protective factors everyone brings with them. From Australian perspective, the health nut study, I'll come to that, the details of this study in a minute. It's very common. So about 1 in 3 infants born in Victoria in health net study, which included more than 5,000 infants from Victoria, had eczema. And the incidence is rising. Now, before I come to, yeah?
I'm sorry for interrupting, Dr. Lalita. There's a question by Dr. Webster. He asks, does environment play a big part in eczema?
Yeah, it does. So when you have one factor out of these 4, which is, say, if you live in a very, very clean environment and you haven't had that farming or bush kind of background exposure to you all the times, you're more likely to have eczema. However, not everyone living in those environments will have eczema. It's only 1 in 3. So what happens to those 2/3 is there's some other protective factors which overpower the role of environment in causing atopic sensitizations or physical disruption of skin barrier or immune overactivity. This really is a fine balance, and it's very hard to pinpoint which factor worked in which patient. But we know as a society, because we see more eczema and allergies, we are definitely heading away from the balance of these factors. And unless we reverse at least some of them, we will continue to see the tsunami of allergy patients.
So probably again, a very similar question. Is there a specific cause, genetic or environmental, which causes skin barrier disruption when eczema presents in infants specifically?
Yes, a very high number of these children who present with eczema early in life would have inherited defect in the physical barrier function proteins or enzymes in the skin. However, as I said before, if there are 4 children in that family inheriting almost autosomal dominant inheritance of atopic genes, so they're carrying the same gene, but they may have a balance of protective factors over that structural defect gene absence, which can compensate for the deficiency of structural protein. It's very interesting, isn't it?
Right.
So you could still have a physical defect in the barrier and may have only dry skin if your immune system was not very hyperactive underneath that skin.
And
so you just have a bit of dry skin, no eczema.
right. And again, with the rise, there's so many questions right now suddenly risen. Why is the incidence of atopic eczema rising? And again, a very similar question. How have rates of allergy and eczema risen over the past 20 years? Could it be processed food by any chance?
Yeah, I think processed foods have their role, and this is why nutritive factors make a major part of this equation,
Right.
which we say, interplay of factors for causation of eczema. So there is research looking into different factors, and definitely processed foods with low nutritional value contribute to immune dysfunction. So different factors play with different parts of eczema pathophysiology, I guess. So in newly industrialized nations where you may still have traditional practices with highly nutritive food and less use of processed foods, the pollution or the quality of air and water they use on the skin could be disrupting their physical barrier as well as causing the immune hypersensitivity. And this is why when we grew up in India, I did my pediatric training in a very busy hospital in India, but hardly saw eczema. I probably saw 3 cases in 3 years, but it's very different in a practice here now. And pediatricians in India are seeing a lot more eczema than I would have seen 20 years ago. Because of that increased pollution, perhaps increasing processed foods as well. And you can see so in fact, the higher incidence of eczema started about three decades ago. The allergies and eczema started to rise in Western society about 3 decades ago. And it has slowed down slightly now with more understanding of the hygiene hypothesis and role of nutrition, people becoming more aware about changing these factors for immune dysfunction.
Right. There's one more question from another doctor. What percentage are cow's milk allergy, and why an increase? Again, increasing questions.
Yeah, I'll come to that with the allergic part, if that's okay.
Yeah, that's perfectly fine. Thank you.
Yeah, I'm touching on that. So when we talk about allergic part, we're talking about progression of eczema to other atopic disorders in the same individual. And when you look at it immunopathologically, we see that allergic inflammation often starts in tissues that have large epithelial surfaces, for example, airways, skin, and gut. And in this steady state, antigen experienced memory T cells, so these are the T cells which live underneath the mucous membrane and epidermis, they actually patrol the peripheral tissues to facilitate swift immune responses against invading pathogens. So that was their basic function. The T cells under the skin, they're supposed to inform other parts of the immune system in the body against a pathogen they would have experienced on the skin surface. But now that they are dysfunctioning and they sensitized to things like dust mite or egg or even the staphylococcal antigens, they then circulate through different parts of the body and pro-sensitize T cells living under the mucous membrane and under the Peyer's patches, in the Peyer's patches in gut. So if you got sensitization from skin, it can be easily transferred to sensitization in other parts of immune system. And how it works is that once the information, the misinformation, I should say, is collected from the local immune system, it goes to the lymph node, and lymph nodes always have a blood supply, which brings the circulating T cells from other parts of the body to exchange that information constantly. And this is why children with eczema are more likely to develop food sensitizations or airway sensitization and food allergy and airway allergies as a result. So this is a slide which holds the key message about food allergies versus eczema. So this is a research done in United Kingdom by Professor Gideon Lack. It was published about 15 years ago, and it has really changed how we started to look at eczema and allergies in children, and ultimately led on to change of the feeding guidelines in about 2016, when I think some in the group would remember that the peanuts and other tree nuts were not supposed to be introduced in children's diet until they started school. From 2016, we've been asking to introduce these allergens from the age of 4 to 6 months. So that massive change in the guideline came from this knowledge that if you introduce the food to the skin first versus gut, you're more likely to end up with allergy. Because the skin draining lymph nodes will spread those T cells to gut before it gets a chance to get a tolerizing process after exposure to that allergen. What it means is gut is a tolerizing organ and skin is a sensitizing organ, because skin is in the front defense. And if there is an immune dysfunction, it has a hypersensitivity response. So if you're rubbing egg or peanut or milk on an infant skin, which has a skin barrier defect, and also a defective or hyperactive immune system, dysfunctioning immune system, you're more likely to end up with a food allergy. Versus if you wash your hands and protect all the food allergen exposure on their skin all the times, and give them food by mouth as soon as you can, which is usually 4 to 6 months for most infants. The antigen gets processed through mesenteric lymph nodes, which are more of a tolerizing sort of, which holds a more of a tolerizing system because of the survival mechanism. Food is so essential to life. So the Lack hypothesis taught us early introduction of food will prevent development of food allergies if your child was already not sensitized to those allergens through skin. So keeping that skin healthy before you introduce food holds the key to prevent food allergies in children, according to Lack hypothesis. And we see that in our clinical practice over and over again. So this concept is also supported and elaborated further by the LEAP study, which was a landmark trial of early introduction of peanut in UK. And what they found was in children with eczema, not only they had enhanced IgE production to foods because they were already sensitized through skin. They already had a defective physical barrier and hypersensitive immune system. And from the environmental exposure to egg or peanuts, if their carers were eating these foods and didn't wash their hands and touch that eczema skin, or even through environmental exposure, sometimes through the air droplets, they got sensitized to these foods a lot more often than children without eczema. And I think a little bit of the slide got cut there. It was meant to show Staph aureus sensitization. The Staph aureus in eczema plays a different role to how it would play in a pyogenic skin infection. And the interaction of Staph aureus with T cells is different in children with eczema. So what happens in children with eczema, the exotoxins of Staph aureus work as superantigens, which means they start making antibodies with the immune system in similar way to how you would make antibodies to egg or peanuts when you have egg or peanut allergy. So it multifolds the effect of staph colonization in children with eczema.
There was one question, Dr. Lalita.
Mhm.
What's social interplay involved in causation of allergic eczema?
Yeah, I have a slide on that too. Thank
Oh,
you.
amazing. No problem.
So that's coming up next from the HealthNet study. So HealthNet study is local Victorian grown study conducted from MCRI in Melbourne. And they recruited more than 5,000 Victorian infants from immunization clinics, followed them through for incidence of allergic diseases, and checked the incidence of food allergy by food oral challenges at 1 year and then 4 year, and then it's still going on. So they produce a lot of useful papers, and there is a summary of their findings in one of the slides I had, this one here. So I hope this one answers a couple of questions asked today. The non-modifiable risk factors for food allergy. Through HealthNet study, the odds ratio, which means that if you had parents born in East Asia compared to Australian born parents, you're 2.8 times more likely to have a food allergy. And it's non-modifiable for that child once they're born. If you have a family history of allergy, it increases your chances by 1.4 times. And if you have a filaggrin loss of function mutation, so filaggrin is a structural protein which causes the physical barrier defect. If there is a loss of function mutation, you are 3.2 times more likely to have food allergy. So here's your link of structural issue with skin with food allergy as a risk factor. Now, potentially modifiable factors were looked into, and they didn't find, well, they wanted to support hygiene hypothesis, I guess, but they didn't find a very strong association with presence of siblings, which is supposed to give you dirty atmosphere and exposure to dog. But they did find that later introduction of egg compared to at 4 to 6 months of age, the odds ratio of having egg allergy was on 1.6 times higher if you were introduced between 10 and 12 months, and 3.4 times higher if the egg was introduced after 12 months. And this was really the paper which prompted change, the process of changing the infant feeding guidelines, which eventually took 6 years to come in existence. The other potentially modifiable factor is vitamin D insufficiency, and that's highly associated. The vitamin D insufficiency makes you 3.1 times more likely to have food allergies or eczema. And factors which they didn't find associated with food allergy were maternal consumption of egg during pregnancy, cesarean section delivery, which has been quite talked about previously. In this study, they didn't find that associated with food allergies. They also didn't find association of duration of breastfeeding with food allergy, age at first introduction of solids in general, because by the time this study was done, early introduction was not a standard protocol. So they didn't have enough children who were introduced early enough. Childcare attendance, which is supposed to bring your hygiene hypothesis. So, saliva and other secretions exposure to other children, cat exposure, use of antibiotics in infancy. So which was very reassuring for a lot of pediatricians who would have treated newborn babies with antibiotics who later went on to have egg allergy. So in Health Nurse study, 1 in 10 children actually had egg allergy, which was challenge proven, but a lot higher numbers had sensitization to eggs, which means the egg allergy test was positive for 3 to 4 times more than 10% of the children who had a food exposure related allergic symptoms. So a positive IgE is formed through the sensitization in the skin immune system, but you may have significant protective factors to offset that risk of IgE antibody interacting with the egg on oral exposure and causing an acute reaction. So I think some of the other mothers in the group will also be needed very soon to put their little ones to sleep.
That's very cute, actually. We did have a question, and there was a doctor who was asking, what do I do with a 15 or 12-year-old under immunologists for severe allergy, causing anaphylaxis and now vomits when even any different food is put in his mouth?
So do you mean they were vomiting to foods they were not proven to be allergic to?
Possibly. That is the
So
question which was sent. Yes.
Yeah. So if I understood the question well, the answer here is if someone has multiple food allergies, it's very common to have high levels of stress for understandable reasons. And then stress-related functional gut disorders are not very uncommon in children with multiple allergies. So vomiting is a non-specific symptom of allergy. Unless they've been tested and assessed for food allergy to all those foods they vomited to, I won't call it vomiting to all those allergies.
15-month-old. Sorry.
Oh, 15-month-old. Oh,
Yes.
Is this in the chat?
Yes, it is.
Oh, so what do I do with a 15-month-old under immunologist for severe allergy causing anaphylaxis and now vomits when any different foods put in? Okay, so when different foods cause physical symptoms like vomiting, it's more like a hypersensitivity, not hypersensitivity of senses, sensory hypersensitivity, not the immune hypersensitivity. So they have an association of negative experience with food, and a 15-month-old hasn't been able to differentiate other foods from that food they had a negative experience to. So they are rejecting that food by being hypersensitive to it, not not allergic to it.
And they're only feeding him yogurt, apparently.
Yeah, I hope the dietitians can help them bring their diet back to norm.
And it's projectile vomiting. Oh, you read that, yeah.
Yeah, so I'm reading the question. So where does patch testing fit in all this? Okay. So I guess the question is whether they have a non-IgE mediated allergy in addition to that IgE mediated allergy to egg. So when we talk about food allergies for the wider group, IgE mediated allergies when you have immediate symptoms of allergies. So you have generalized rash, facial swelling, you can have immediate vomiting. We're talking about symptoms onset within minutes quite often and up to maximum of 2 hours. If it happens after 2 hours, we don't call it immediate food allergy. And if you have non-IgE mediated food allergy, the allergen may not cause any symptoms for 24 to 72 hours. Non-IgE mediated food allergy cannot be tested on conventional skin prick testing or conventional blood allergy testing. The most definitive diagnosis of non-IG mediated food allergy is gut biopsy before and after the exposure to allergen. Patch testing is not validated to diagnose delayed food allergies. I hope that answers your question. So I think from a pediatrician's point of view, the projectile vomiting to multiple foods causing restrictive feeding patterns should be managed with the help of speech and language and occupational therapists, because this is a child who really need a sequential sensory approach to feeding, which means desensitizing them to texture of the food before they learn to accept it. So it's nothing to do with allergy to multiple foods. It's a behavioral response to food allergy, which is extreme, but we do see it time to time. Do I launch a poll? Why not? So please, Nazia, do you want to launch a poll at this stage?
Yes, probably a little break for everyone, then they can just read the sequence.
Yeah, sure. Will I see the poll as well?
Yeah, absolutely.
Do I stop sharing?
No, that's fine.
Okay.
I have actually launched it, but
Perhaps I have to stop sharing.
I'm unable to launch it somehow. No, that's okay. Oh, I was sharing the previous one. Okay. Okay, I'll come back to that. Maybe you continue, Dr. Lalita. Sorry for the break.
That's all right.
Thank you.
So I hope that answered that question. And it actually ties in with that question about milk allergy. So allergy is not allergies children who have immediate reaction.
Hi, I understand. I think the network got broke up in the middle. Yeah, I understand. I can also not hear Dr. Lalita. Maybe we can start with answering the poll, and I'll just prompt Dr. Lalita. I think it's a little bit of network. Yeah, we can hear you now. I think there was a little disruption, and I launched a poll, so probably we'll just wait for a couple of seconds, and then you may have to repeat the same thing. Sorry about
I'll do that. No, that's absolutely fine.
Thank you, everyone, for prompting that out, so we didn't miss out any important detail. Yeah, we have about 50% of the people who have voted. We'll just wait for a couple of more answers. Is the question visible to you, Dr. Lalita?
Yeah, it's actually not an absolute sequence all the times, but it's the most common sequence.
Okay. Dr. Azka, it should be available on your screen. We have almost, yeah, probably I can just end poll and share the answers. A few doctors couldn't see the poll, so maybe they'll be able to see the results. And I've shared the results. Is it visible for you, Dr. Lalita?
Yeah, I can see the poll.
Okay.
Yeah, so the answer is the first one, which most people have got it right.
All right. So I can actually try and launch another one, maybe?
Yeah,
is that
sure.
okay? Sure.
Yeah.
I think you've just covered this like a couple of minutes ago. So the next question is, which one of the following is a primary consequence of a disrupted immune and physical barrier in children with eczema? All right, Dr. Kumar, we'll make sure that the results are visible for a little longer. Sorry about that. I hope everyone can answer this time. And thank you everyone for your patience this evening. Dr. Rashid says that he cannot see the poll. I hope I can make this better someday, but probably today I'm stuck with a few tidbits and pieces. I'm so sorry for people who are unable to answer, but from next time onwards, we'll make sure we make this better. I apologize. All right, we're almost a little more than halfway, so yeah. Okay, I'll share the results and then you may continue, Dr. Lalita. Thank you so much. Yeah, the results are shared.
Thank you. So I'll just make a comment on this poll question as well. So
Sure.
the physical barrier disruption causes not only the susceptibility to allergen sensitization, but also active inflammation due to a hyperactive, dysfunctioning immune system. Okay, so when I think the internet was playing up, I was trying to answer the question about milk allergy. So yeah, so all allergies are a lot more commoner than what they would have been when we were children. And we discussed what factors could be contributing to that. Milk allergy is one of the commonest food allergies. Egg is the commonest food allergy. Milk allergy is slightly different to egg allergy because majority of children with egg allergy will present with acute allergy type symptoms, which is mediated by IgE antibodies. So very easy to diagnose on IgE testing, whether you're doing a skin prick testing or a blood testing. On the other hand, acute milk allergy is not half as common as non-acute or non-IgE mediated food allergies, which is primarily the gut type of problem. So you have, I'm sure all of us have met these babies who have a lot of diarrhea or reflux or failure to thrive, a lot of mucus, sometimes blood in their stools. And that milk allergy is not related to IgE sensitization at all. So there is no blood test or skin prick test which can reliably diagnose those symptoms. Although food allergy sensitization is very, very high, especially if you have a disrupted skin barrier, but that doesn't mean your sensitization is going to cause food allergy, which means you may have, so the Health Nuts group also did a study on peanuts. So about 50% of the children who were positive to peanut allergy test tolerated peanuts when they were fed in hospital. So the food allergy testing is really rubbish when it's positive. It's really good when it's negative. So when I see a negative test, I can feel very confident this child doesn't have allergy to that particular allergen, which is negative on the blood test or skin prick test. But when it is positive, it could be merely a sensitization, not a true allergy. What makes sensitization a true allergy is when the immune system activates in presence of an allergen, which means people who have a positive allergy test but no reaction on exposure to food must have some protective factors which protects those immune reactions. Immunologically, we know the parts of immune system which provide that protection, but they're not routinely measured in clinical practice. I hope that makes sense and it's not very confusing, but this is my job day-to-day in allergy clinics to differentiate people with sensitization from real food allergy. Because a lot of people with sensitization can lose that food in their diet if we don't explain it to them that they're not allergic to it. So I have a lot of referrals with a positive RAS to staple food mix. And then my job is to work out if this child has a food allergy to any of the foods in the food mix or not. So taking, allergen-wise history. So when you took milk, if you had any symptoms, and when I mean symptoms in terms of a food allergy test, they have to be acute symptoms. So symptoms which start within 2 hours of intake of the food, not symptoms which happen a day later. So eczema exacerbation due to food can only happen through contact, not through ingestion of the food. And it shouldn't reflect in the blood test, because if it's reflecting in the blood test, it should be that immediate reaction to egg. It's a little bit confusing. I'm going off track. I'll keep on track with the eczema talk. But next time, I'm quite happy to do this discussion on food allergy. I'll be happy to do a presentation on food allergies. So this was a slide I always used to use during my previous work in SAIL. I just put in for this presentation as well. So we know that when people are drowning in the delusional ignorance without knowing that their suffering was created by themselves, it suits the T cells very, very well. So they're trying to fight against things which they shouldn't be fighting for. So they are trying to react to pollens or dust mite or foods, which are usually friendly in terms of allergies. The allergies are reaction to those benign things in our environment. The immune system has distracted and created this misery for ourselves. So just coming to the management of eczema and how it relates to the pathophysiology. So we're saying that eczema is not caused by food allergy, although food allergy may be caused by ongoing eczema or skin inflammation. So what we do about eczema is really that barrier repair. So we can do the physical barrier repair by using any of the creams which moisturizes the skin well and doesn't introduce irritants, which means creams without fragrances or major food allergens, or even the natural products, because those ingredients could interact with the overactive immune system in the skin and cause further inflammation. So the best cream is really something like a liquid paraffin-based cream with water and very little preservative, so it doesn't become stinky after 2 weeks of mixing the water with the liquid paraffin oil. So most of us are familiar with QV cream or Cetaphil cream and Sobolin. So they're pretty suitable. The thing to remember about these creams is anything which has too much fat in it, so something like Vaseline, can be counterproductive because it could reduce the escape of heat from the skin, and heat can trigger immune system to overact. So something which has a balanced amount of water and fat, which is the cream base, is the most effective barrier for active eczema. If you've got a very, very dry skin but no inflammation, Vaseline may serve very, very well. On the other hand, lotions may not be moisturizing enough to protect that physical barrier which is disrupted. So I recommend cream-based moisturizers for active eczema. So they just nicely fill in the gaps in the skin physically, but remember they're doing nothing to that overactive immune system or already present patches of inflammation. So we're going to use steroids to reduce the immune dysfunction, at least temporarily. So whatever exposure is trapped in there through that physical barrier defect, the immune system will keep reacting to it unless we cover that reaction with the steroid cream. So we suppress it temporarily until the natural defense mechanism cleans the skin out from all these irritants which have gone into the skin. So in healthy individuals, it takes about 6 weeks to replace the barrier as a whole, because skin always grows from inside out. So you can give 6 weeks of good surveillance to have a very good break from eczema.
And Dr. Lalita, what about coconut oil as a barrier?
Yeah, so that's a really good question and very common question in my clinics. So coconut oil is a fat-based ingredient, and it does have a food which can potentially interact with overactive immune system. So theoretically, any food oils applied to eczemated skin can cause that food allergy, because the immune system can get sensitized to that food allergen. And because of the lack of water content, it doesn't provide the best barrier for disrupted physical barrier of the skin. Now, it could be a good option for maintenance because it can potentially have the type of fats which promotes ongoing health of skin, but it won't be good to be used in the active inflammation scenario. So once you've got rid of the inflammation, for a maintenance, you can go to a fat-based moisturizer or a lotion-based moisturizer according to the humidity and temperature levels of the environment.
And what is the name of the cream which has more Vaseline content to be avoided?
So the ointments.
Yes.
The Vaseline, Dermis ointment, the Epiderm ointment, they're not good for active eczema. So they could be good for, say, if you're traveling for 24 hours and you know that the flight is going to dry the skin out because you've got that physical barrier defect in your skin, they could have a really good role to protect your physical barrier during that 24-hour long flight if you don't have active eczema.
So better preventative than treating. Okay.
Yeah.
And what about Dr. J. Giri? I'm pretty sure I'm mispronouncing it. I'm really apologize. What do you think of shea butter? Commonly used in dark skin people? Yes.
Yeah, so shea butter, olive oil, anything which comes from plant products, it can theoretically interact with the overactive immune system and cause sensitization. So I said theoretically, but there is actually, there are a couple of case reports where people were using oatmeal for eczema or goat soaps, goat-based skin products, and they developed anaphylaxis to oats and goats. Not goat, sorry, goat milk. In fact, there was a 20 million pound lawsuit in UK against a goat milk products company done by a lady who had eczema and developed goat milk anaphylaxis. And they quoted lack hypothesis, Gideon Lack's research to win that lawsuit.
Right.
So anything with food shouldn't be on the skin which has a physical barrier disruption because that's invitation to problems.
Okay.
Yeah, however, I know millions of people would have used it and wouldn't have had a problem, but they had not gone so far with the immune hypersensitivity, I guess, before these products were used. Or the balance of the immune system was more in the protective mode than the disruptive mode. So the third cornerstone of eczema treatment is anti-infective measures. And when I was training in UK, I moved to Australia 10 years ago. It was a very common practice to give antibacterial ointments or capsules or liquids, antibiotics to children with chronic eczema. Because by that point, we did know that staph was playing a major role in eczema inflammation, but the practice of using bleach baths was not very common back in first decade of this century in UK. However, it was introduced in America and Australia in 90s and found to be a very effective agent to reduce that staph sensitization and eczema inflammation. And in my clinical practice, and so is my colleagues from RCH and now in Queensland, there is a dramatic effect in eczema skin once you start using daily bleach baths. And it's not a treatment for a day or two, because bleach reduces a lot of irritants by physical cleaning as well as antibacterial action in the topmost layer, which comes in contact with the bleach water during bath. So you have to allow for all those 5 to 6 layers, at least 5 to 6 layers of skin, which have been trapping these antigens and irritants for a very long time. So they have to renew to something allergen-free, irritant-free layers before you stop using bleach, and then you use bleach as a maintenance. Now, other ways to intensify eczema treatment is to use wet bandages, wet wraps, and in my experience, Chewy Fast does an excellent job. And they've been making Tubifast garments for, I think, good 10 years now. So you can use gloves and socks and vests and hats made out of Tubifast, ready-made garments from Tubifast, which you can use to intensify the action of all your creams, because it's like a pressure bandage. So once you put the moisturizer, you've done the bleach bath, put the moisturizer, then the steroid cream, and then you put the stretch bandage on the top of everything, which helps to push the treatment inside the skin layers, plus provides physical barrier to scratching. So every time we scratch, we increase the inflammation, because damaged skin is a trigger for release of inflammatory chemicals. So we want to reduce scratching to intensify eczema care. Sometimes I have to use antihistamines for that purpose. And a good sleep after doing a bleach bath, steroid cream, the moisturizer, a wet wrap with a dose of antihistamine is invaluable in healing of that skin. That really is the holistic care for your patient when they can sleep well after your eczema prescription.
There's a question, Dr. Lalita. What concentration of bleach should be used?
So the concentration of bleach here is it's 5 parts to 1,000 parts of water. So 995 parts of water and 5 parts of bleach. And how you work it out is 12 milliliter of bleach to a liter of water. There is a handout from RCH, and I've got a link at the end. So I hope I've convinced you that eczema is outside in, not inside out. The people often come to clinic and they say, eczema only started in my child when I started giving him formula feed, or she had her egg for the first time. However, they probably didn't notice the skin barrier defect or immune hyperreactivity happening before introduction of that food. So in reality, it's really the environmental exposure interacting with that hyperactive immune system which causes eczema, not the antigen going from bloodstream to the skin causing that inflammation, which was our concept, 2 decades ago. But the understanding of eczema has come to a stage we know it's definitely outside in, not inside out anymore. And I think we all recognize that stress is an important factor for many chronic diseases. Eczema and other allergic diseases are all chronic diseases and have a potential to cause pervasive stress in the family, whether that's because of lack of sleep for months and years, or because of that threat of acute anaphylaxis and death due to severe food allergies. So reducing stress improves eczema and other allergies. There are plenty of research documenting that. So I always talk to my patients about stress management when I see them for eczema care. And I try to show them this brick and mortar model of skin, where we want to make the mortar so strong that the irritants stay out and moisture stays in. I always tell them, don't stress, do your best and forget the rest. So these are the links for very, very useful links, which I like to share with all my patients. So there is this bleach handout from RCH website and information on eczema, very useful information. And this new website in last couple of years, which gives really good guidance on how you can prevent allergies in your children. They talk about how you can introduce allergens early. So practical tips about introducing allergens early and managing eczema. So you can change the course of one's life. You manage the eczema so well that they have no food allergies, no airway allergies, and no asthma. You change their allergic march. Thank you. I finish with that.
Thank you, Dr. Lalita. That was very informative and changed my perception about a couple of things. So thank you so much. Is there anyone who has any particular question? Oh, there's one question. Do you have any recommendation about steroid creams?
Yeah. So there is one question before that. I'll answer both. So recommendation about steroid creams.
Yes.
So we like to use newer steroids, which have less skin thinning effect. The newer steroids like Advantin methylprednisolone. I like to use the Advantin ointment because it's a little bit more potent. But remember, you're only using steroid on the active eczema. And I write in my letter to patients to use it on red, rough, and itchy areas of skin. Because even if it's not red and rough, it's only itchy, it's active eczema. So you should use steroids. And sooner you catch that immune reaction in skin, less amount of steroid you have to use. So you may be able to control that immune hypersensitive in the skin with 1 day of steroid if you started it as soon as it started to become itchy. And you can use Advantin, and the other one is mometasone. Again, I use ointment on target areas and a cream-based moisturizer head to toe, which should be applied about 5 to 10 minutes after the steroid application. The next, another question was what concentration? Oh no, we covered that one. There was
probably what about the face?
the face. Yeah. Okay. Yeah. Thanks, Dr. Padma. So, so the Advantin and mometasone, they're medium potency steroids. And in infants, we say avoid using them in nappy areas and face areas. So face, we say brow to chin. Anything on the forehead or neck or scalp, you can go medium potency steroids. Low potency steroid, 1% hydrocortisone or 1% dermid cream is a good formulation for face, or 1% hydrocortisone generic ointment is quite effective as well. For nappy area as well, if you use the steroid, the presence of nappy, the humidity, moisture, and occlusion increases the effect of steroid. This is why you want to stick to mild potency steroid in nappy areas. And facial skin is sensitive. That's why the mild potency for face. So that's pretty standard prescription for my patients, 1% hydrocortisone and Advantin, and sometimes mometasone.
All right. What about Elidel cream for face?
Yeah, so Elidel has specific indications. So Elidel has a steroid sparing effect. It's not a steroid, it's an immunosuppressive from the class of tacrolimus. This is the macrolimus we're talking about. So you can use tacrolimus as well, although it's not very widely used in Australia. So if you want to give it on a Medicare script, you can use it only for specific indications, which is your eyelid eczema or your perioral eczema. So when you have eczema in these areas, you're more likely to have chronic side effects of steroid use. And that's the point of using Elidel, so steroid sparing effect. Sometimes you find that eczema is so active that 1 week of steroid is not cutting it, but you need an ongoing anti-inflammatory, which Elidel is. However, Elidel is not as potent as steroids. The potency is lower, so it needs a longer course. So you want to use Elidel twice BD for 2 to 3 weeks before you bring it once a day use in children with chronic eczema. Only reason I use it in infants is for perioral eczema, because I don't really see very severe lid eczema in infants. And it responds very well to bleach baths and 1% dermid cream in infants. In older children where chronic lid eczema has been there for a very long time, Elidel is very useful. Because lid is obviously a very thin and sensitive area of our body for steroid damage.
Do you have that question out? Is it safe to use hydrocortisone for eyelids eczema? Can it cause thinning of the eyelids?
So it can in long-term usage. So we advise 5 to 7 days for facial eczema. For body areas of eczema, I say steroids can go up to 2 weeks. And if someone had chronic eczema for 6 months or 6 years before I see them, you can imagine the state of immune system in the skin, as well as the physical structure of skin will be highly disruptive. So 2 weeks of steroids is not going to cut it. So quite often I go 2 weeks of daily steroids, followed by alternate day for another 2 weeks for body areas of eczema. For eyelids, I do daily for 5 days, and then alternate days for another 5 days. And if that doesn't cut it, I move to Elidel.
All right. Thank you so much, Dr. Lalita. Do we have any more questions? We still have a couple of minutes, and if you guys have any other questions, please feel free to share that. So there's a question: how to reduce stress in a baby?
No, actually, it's not a silly
think it's
question. It's a very important question. So it was about, I think, 5 years ago, when I joined the infant mental health course. It was an eye opener. The parental stress pre-conception and post-conception is directly related to stress of the baby, and it causes all sort of physiological and pathological consequences. So the easiest way to reduce stress in a baby is to reduce the stress in the primary carer, which is not easy, I guess.
There's also 2 more questions. At what age would you expect eczema to settle down, if at all? It was started at a younger age.
Yeah, so again, great question. So when we look at the pathophysiology of eczema, and we are targeting care to that pathophysiology, in many ways you are causing an immunomodulation and you are changing the course of the disease, which means if you catch it early and treat it early before the strength and population of memory cells, which cause immune dysfunction, is not very high. And this is what helps you to not have eczema in long term. So I've seen babies with very severe eczema head to toe. If they present to me at 3 months, by 8 or 9 months, they're remaining with very mild eczema if parents choose to continue with the management plan, which often is 3 months of bleach baths to start with for severe eczema at any age, and then bleach baths on flare-ups, steroid creams to start with until all eczema disappears, and then rapid or prompt treatment on recurrence. If you keep going that way, you are reducing the hypersensitivity of immune system. So you're actually doing a disease modification by that prompt treatment. The disease modification of eczema, as well as disease modification of allergic march. And a lot of babies do extremely well if we get on the top of the eczema early on. So they're eating all those foods because it's a standard practice to give allergen introduction advice to all infants who present to clinic with eczema. So I get them on all these highly allergenic foods before they become allergic to it while I'm treating their eczema. So that way, you can make a difference.
Right. That's very nice. Also, what is the percentage of glomerulonephritis in eczema?
I'm sorry, I don't have the answer to that question. I'm not sure. In children, I don't see that. Anecdotally, I think it's a chronic inflammation. So theoretically, it can probably cause issues if you have years and years of eczema, but I haven't come across that in pediatric population.
All right. We're almost done with the session. Now, if there's any other question, please feel free to just send us the questions, and whatever is unanswered, we'll make sure that we get back to you in an email. Thank you so much, Dr. Prakash. That's really nice of you. They give your compliments, Dr. Lalita. That was very informative.
You.
I will be sharing a review performance now. So this link needs to be filled out for the review performance CPD hours, and I'll also share my screen for the QR code, so you can actually get the the form from the web page. Thank you so much. It was very informative.
I thank everyone for sparing this time to spend with us, and also for your interaction. I really enjoyed your interaction. I hope you got something out of it too.
Thank you, Dr. Lalita. It was really a pleasure having you, and it was really very informative. My perception also changed a lot. I had really many
I'm glad to hear that.
misconceptions. I'm serious. So thank you so much for that. And if there's
Thank you,
anything, is that
everyone.
okay? I'll send you in an email and you can just give back the answers. And also the links, if that's
Absolutely.
okay. Thank you so much.
Yeah, sure.
Yeah.
Yeah, no problem.
Okay.
Thank you. Good night,
Have
everyone.
a lovely evening, Dr. Lalita. Thank you so much.
Thank you. Bye.
Bye-bye. For everyone who's still online, I have shared the link and this is going to be there for another 10 minutes. So please feel free to just fill out the forms and submit them as soon as possible. And before signing out, I will definitely give a little goodbye. And meanwhile, I'm just going to close down my video and the QR code is going to be there. And the link has already been shared in the chats. Thank you so much. Thank you for all the patience.
I'm actually sharing the link in the chat now from
Oh,
my
lovely.
slide, but I'll
Oh.
also, I mean, you could circulate it with the email
Absolutely.
as well.
I will just share this in the chat and I can send it in the
Oh
emails
yeah,
also.
sorry if we send it to everyone.
Yeah, that's okay. I sent it now.
Thank you.
Yes, okay, I have a question. How do you use the link on the screen with the computer? So you hold the camera in front of the computer and then there will be an automated link which will come up just under the QR code. So if you click on that particular link, there will be a form which will automatically come up and you can choose the answers. It's a multiple choice questions and it should be fairly easy to answer. You're welcome.
Thank you, Nazia, for your help. You put a lot of work and effort for making this session happen.
Thank you, Dr. Lalita.
You've done very well.
It's my pleasure.
Thank you.
Thank you. You're very kind and polite. Thank you. Have a good night. And
Have a good
I'll
night,
touch base with you
everyone.
soon. Thank you. Bye-bye.
Thank you. Bye.
Hi, good evening, everyone. Once again, since all of you have access to the forms, I would like to close the day. Thank you so much. Have a very pleasant evening and a very good night and a beautiful weekend. I wish you all the best. And also, could you, we would send an update for the next session. It is on the 8th of June, 6 to 9, and it's focused on mental health primarily. It's by a psychologist and by a psychiatrist. So feel free to shoot any questions on gp@telecare.com.au if you have any questions or concerns regarding certificates, CPD hours, or anything of that sort. It was lovely to host you guys today, and it was a lovely session. Thank you, Dr. Gautam. Thank you likewise. Thank you so much and have a good night. I appreciate that. And please feel free to put in any suggestions that you guys have. We would be happy to appreciate any sort of positive criticism or constructive criticism and suggestions to make the activity a little better. We did remove the performance reviews from last time to just one, and including polls and more interactions. So if there's anything, please feel free to shoot us a message or an email. Thank you. Bye.